We're going to do a quick switch and feature Dr. Hendifar for the LACNETS case right now. And
so this 53-year-old gentleman who presented with multiple liver lesions, and his case presents way back in 2007 when he had flushing and mid-epigastric pain. At that time, imaging showed a right lower lobe lung lesion, and he had surgery for that. And here I pulled up a picture of a PET scan circa 2007. And you can see that lesion on the right liver, on the right lung, I'm sorry, right here. So it was read as a typical lung tumor, 2.5 centimeters in size. There was less than 2 mitoses per 10 high-powered fields. The Ki-67 was less than 5%. It was called a well-differentiated typical lung carcinoid. So the classification system for lung neuroendocrine tumors is as such. Here, and I made this figure, but I didn't do a good job. I would have switched these two around. But anyways, it goes from typical carcinoid to small cell lung cancer, from your left to right. And as you see, the two criteria that we use for these low intermediate grade tumors is mitotic figures and necrosis. So if you have necrosis and you have a certain amount of mitotic figures, it used to be per 10 high-powered fields, now it's different dimensions, but you can see here there's a little bit difference here between these two groups. Then you have the high-grade tumors with large cell neuroendocrine carcinoma, which has large cells but a high proliferative index, and small cell carcinoma, which just simple enough based on the description of small, they're small cells, high proliferative index. And this is an important designation because it dramatically changes the treatments you should be receiving. And here is a nice picture, pathologic picture, corresponding with, typical low grade, atypical low grade, large cell high grade, small cell high grade. And those dots you see is the Ki-67 staining, the brown. So, and which is very common with lung neuroendocrine tumors. They were seen by a surgeon. Surgical guidelines are after a typical lung tumor, you get a CT scan of the chest, and you just do it for 5 years and then you're done. So in 2012, he got his last CT of the chest. He got the balloons, his hand was shaken, and he said, "You're good to go." Unfortunately, in 2014, a couple years later, he had elevated liver function tests. And ultrasound revealed liver lesions, and these were biopsied. And here's an MRI of the situation, and here you see pretty sizable liver lesions. So a biopsy was done. This was found to be a well-differentiated neuroendocrine tumor, compatible with the lung primary. Now, normally, someone asked earlier today, well, how do you know? How do you know that's from the lung? And, what do you guys are kind of, how would you know? And the reason is that we don't know 100%, but there's no other source it could probably be from, and it kind of fits the whole picture of being from the lung. Okay, the octreotide scan was indeterminate. Here's the octreotide scan. This is a shout out to the nuclear medicine physicians, because I'll show you a gallium scan in a few pictures. You can see how much better quality it is. And then the patient went on to receive a liver surgery. And you saw the sizable liver lesion. So they had a cytoreductive liver surgery, and this kind of gives you an idea of what happened. So removal of multiple large confluent masses, removal of multiple confluent hepatic masses, small 1 centimeter masses that are removed, microwave ablation of 3 of them, and alcohol ablation of 1 that was tough to get to otherwise. So you can see that. And here's the pathologist. So the surgeon does all that work. The pathologist is not to be, pathologist doesn't want to be outdone. So the pathologist gives this long description of this path specimen. So heroic effort, a lot of the disease is removed. And you can see there's a lot of thought to this. And if you read the comment, the tumor has trabecular and insular pattern. The mitotic count ranges from 2 to 3 per 10 high-powered fields, raises the possibility that the tumor might be transitioning from typical to atypical. However, the Ki-67 is low, less than 5%. There's no necrosis. The computer-assisted image analysis shows that the lymphocyte nuclei might confound the Ki-67. The immunostain confirms the diagnosis for carcinoid, but not specific to site of origin. So very complex, a lot of thought that goes into this from the surgical perspective, the medical oncologist, even the pathologist perspective. So just to kind of see what goes on in the background. And these are the types of stains that are placed on the path report, again, to kind of help characterize these tumors better. And this is the result on pictures after the surgery. It looks a lot better. I did cherry pick the images a little bit, but it was a lot better after surgery. Now there was, even after all of that work, there were still a couple of tumors left behind. And that's not to be unexpected. When the surgeons do a debulking surgery, they don't expect to get 100% of it. So we saw a little bit left, wondering what to do. Do we do sandostatin therapy? Do we do surveillance imaging? Do we do nothing? And of course, more tests. So in general, what types of therapies are there for lung neuroendocrine tumors? And it really depends on what type of tumor you're dealing with. If you're dealing with an atypical or a typical carcinoid that has strongly positive somatostatin receptor expression, you might consider octreotide or lanreotide. You should definitely consider everolimus, which is recommended as first-line therapy for these. Chemotherapy is reserved for the large cell and the small cell, and PRRT, as we discussed today, can be an option. But really, it really depends on the biology of the patient, of the tumor. That's the most important issue. So here is a patient who has that kind of fuzzy octreotide scan, and here you see a really nice gallium-68 scan with several lesions that are clearly defined in the liver. Okay. Well, the patient had somatostatin analog therapy and 18 months of disease stability and then some progression. So of course, many of you learn a lot about your neuroendocrine tumors outside of your visit with the physician. And every day I have interesting questions, kind of like what we talked about today. And this particular patient said, you know, I've read a lot about cancer immunotherapy in all these journals, and you know, I've heard this is doing great stuff for cancer patients. What about me? I said, okay, that's a good point. If you look at, so one type of tumor, biologically speaking, that does do well with immune therapy are tumors that are what's called microsatellite unstable. And I was thinking that he might be a candidate for this type of treatment. There is some evidence that neuroendocrine tumors do have some rate of microsatellite unstable, you know, do have some microsatellite instability. It tends to be the higher grade tumors. But I said, why not? Let's check his tumor to see if he has this biological characteristic. So the way that this is done is certain proteins are looked at in the tumor, and sure enough, he was missing a couple of DNA repair proteins, MLH1, MSH6 was positive but quite low. So this was really interesting. So we thought he may, you know, maybe this is a microsatellite unstable tumor, and he qualified for a pivotal clinical trial looking at immune therapy for these types of cancers. So we talked about it. We talked about our different options. We talked about the risks and benefits. We said, hey, this might be a good idea. Let's give this a try. So he went on that study. Then the lung pathologist, who actually specializes in neuroendocrine tumors, he's like, Andrew, why do you keep ordering all these mismatch repair DNA proteins on these tumors? Like, why are you checking all these things? What are you guys doing here? He became interested in this idea of maybe lung neuroendocrine tumors being microsatellite unstable, and he submits a research proposal, kind of seeing in real time how these things develop, how these ideas cross-pollinate, and how certain treatments come from one field of medicine and kind of filter through. So he was placed on immune therapy, and after 6 months on immune therapy, the tumors grew again. And so finally, now the patient was recently started on treatment with everolimus, and just recently started. Now, everolimus has been approved for treatment of patients with well-differentiated lung tumors. It's probably the best evidence-based treatment for this disease at this time. So if you have a typical or atypical carcinoid, the patients who were placed in this clinical trial did quite well. It prolongs the amount of time it takes for the tumors to grow by a significant amount. Now, the other treatment approaches that are possible include somatostatin analog therapy for patients who have the receptor, like lanreotide or sandostatin. But honestly, there's not a lot of good data yet to support their use. So there's clinical trials that are ongoing. So it's probably best to enroll in clinical trials if you have a lung neuroendocrine tumor. And the other possible option, like we discussed, is PRRT, if you have the receptors on the octreotide scan or on the gallium scan. But that's also kind of pushing the boundaries of what our understanding is, and it's probably best to enroll in a clinical trial if it's available. Okay, hopefully that was helpful, and thank you for your attention.